So this is the Prostate Cancer Lab. I'm Brad Power, and we're very honored to have Dr. Oliver Sartor with us today. Our standard disclaimers are that, first of all, this is not medical advice. This is just information that you can take to your medical team. You shouldn't act on anything that you hear today without getting professional counsel. Secondly, I like to call it your Miranda rights. Anything you say can and will be used will be published. So you should expect that anything you say or your image, this is going to be recorded and published on the web. So your image, whatever you say, and your name is going to be public. So if that's a problem for you, turn off your screen, change your name, and don't say anything. All right. So so let me just do a quick introduction to Dr. Sartor. I think, Oliver, you'll remember that part of our connection is through Jeff Hoffman, who was I guess a classmate at yours at Tulane.
Yes.
Back in medical school. Yeah.
That's
and
correct.
Jeff Hoffman is my cousin. And he's an eye doctor in Providence, Rhode Island. But anyway, I think Jeff pointed me to Dr. Sartor, and Dr. Sartor has been very helpful to helping provide advice to a number of the patients we've had initially with, I think, Bryce Olson and some of the choices that he faced. So we're very pleased. There have been a number of patients in our community who have requested to hear and have a conversation with Dr. Sartor. So we're very pleased. We scheduled this time just to accommodate his schedule. Maybe he'll tell us, but he's moving from Tulane to Mayo Clinic. Does that mean a physical move for you, Oliver?
Yes, I realized I pulled up these slides and it shows me still at Tulane. I'm at Mayo now, and happy to give you my email and stuff like that. In fact, let me put that in the chat. But yes, I'm physically at Mayo now.
Okay, so you're beaming to us now from Minnesota?
I'm beaming to you from Minnesota. I'm in Rochester, Minnesota, right this particular moment.
Okay. Well, with that, I'll turn it over to you. What we discussed, for those who didn't hear, Dr. Sartor is going to run through a few slides really quickly, 5 or 10 minutes, and then we will mostly have Q&A for 50 minutes. I should reiterate some email conversations we had about questions that patients had, and there's a request that you focus on castrate-resistant prostate cancer patients who are sort of beyond hormone-sensitive prostate cancer, so that we get kind of the skinnier branches of people that are more advanced as much as you can. Thank you.
Yep. Yeah. Sorry, there's some background noise, so whoever is not on mute, if you can mute, there's definitely some shuffling around. So if you're not on mute, please put yourself on mute and then come off mute when you're ready to ask a question. Thank you.
All right, so yes, I'm in Mayo Clinic right now, and I don't see the chat when the way it's presented, but I'll get that up for the end of the time. I've been doing advanced prostate cancer a long time, and I think first of all you have to have some feeling for where the field is before you can kind of understand the rest. This particular slide sort of encapsulates all the phase 3 trials that have been shown to have an overall survival advantage. All of these are in New England Journal except for one. That's the Tropic trial. And we have a variety of things that I think are sort of noteworthy. So first, I'll make a comment that when you look at the overall survival benefit, I think the first thing that you would conclude as a patient is that this is pretty unimpressive. And I think it is. It's not as impressive as we would like. But this is the reality. And there are a variety of reasons for this. There may be crossover, but nevertheless, these are factual data that I think is important for people to know. And I distributed the slides in advance. A couple of other things. The field has really been changing since the early trials showed a benefit. Things like sickle cell T, to be honest with you, that's Provenge. I don't know how relevant it is today. The same is probably true for radium. Simple cell T was FDA approved in 2010, radium FDA approved in 2013. And there's really been a wholesale change since then. If we want to look at the clinical decision making, and I could spend an hour on this, but I won't. You have to kind of think about, first of all, what is available and what is affordable. And that's not always so clear. A lot of these things are very expensive now. So that's really a problem. There are a lot of therapies that may not be suitable for everybody. You know, performance status, age, comorbidities, laboratory assessments, symptoms, all sort of dictate how we think. Prior therapies, response and resistance and duration of prior therapies. I just spoke to a patient today. You know, he underwent chemotherapy with no response. You know, I'm probably not going to give him another chemotherapy. Tolerance and intolerance of prior therapies, burden of disease, oligomets, non-oligomets. Where's the disease located? Bone only, liver, pelvic lymph nodes only. Makes a big difference, particularly liver. Liver is a bit of a challenge. What about the pace of the disease? Is it rapid or slow? And it's very different for different people. If there's progression, is it systemic progression or focal progression? What about phenotypes? You know, we talk about adenocarcinoma like it's the only thing that there is, but it's not true. They're anaplastics and neuroendocrines. They're molecular biomarkers, BRCA being a clear one, image-based biomarkers like PSMA and FTG, clinical trials, options, you know, what's out there, what's not out there, adverse event profiles and patient preferences. So all of these fit in. Imaging is important. Genetics are important. Histology is important. Prior treatments, all of these are really critical. So when we begin to look at sort of the current landscape, you know, the novel hormones are all going up front. So everybody gets a novel hormone, and that could be abiraterone, enzalutamide, darolutamide, apalutamide. Everybody gets a novel hormone, and it typically is even before you get to be metastatic CRPC. Once you're metastatic CRPC, there's our conventional things, and then there's PARP inhibitors and pembrolizumab, PSMA, lutetium, and radium that are sort of specific for certain populations. Again, I want to keep this brief, but this is from the NCCN guidelines 2023. You can sign up and get them, but sequence matters. You know, if you have not had any of the novel hormones and all you've had maybe is an old anti-androgen, something like bicalutamide, then, you know, I will use abiraterone or enzalutamide typically in that setting. If we're going to be looking at the post-androgen deprivation and docetaxel, a little bit of an older patient, I'm still looking at the hormones. I'm looking at abiraterone and enzalutamide typically as my number one and number two options. If you've had an androgen deprivation therapy and a novel AR pathway inhibitor, that's the patients who have abiraterone, enzalutamide, apalutamide, darolutamide, then, you know, docetaxel is currently category 1. That may change, but docetaxel is sort of category 1. And if you've had both, then probably, and I'll say both, I mean, docetaxel and a novel AR plus ADT, of course, then we're probably looking at Pluvicto or lutetium-177, PSMA 617 as being sort of the path forward. But you also have to understand that genetics are real, and there are a variety of things. Now, these are our molecular and image-based biomarkers. We have a homologous recombination of paired genes like BRCA2, BRCA1, PALB2, RAD51L, etc. PARP inhibitors can be effective, particularly for those who have BRCA2 mutations. You have a BRCA2, PARP inhibitors can really be quite important. Probably BRCA1, PALB2, RAD54L. A lot of the other ones, not so much. Mismatch repair genes, and there are 4 of them, but there are 2 that we understand a little more than the others, MSH2, MSH6. And here we have pembrolizumab as an FDA-approved option. It's very important. And then Pluvicto for PSMA PET positivity. when we look at these biomarkers, they can be either tissue or circulating tumor DNA based. There are a variety of DNA repair defects that are noted if you look at the tissue-based genetics. And we have things like olaparib that have prolonged survival in individuals with metastatic castrate-resistant prostate cancer. But not all the genes are created equal. That's very, very important. The genes that seem to be particularly sensitive are BRCA2, probably BRCA1, RAD51B, maybe RAD54L. And it turns out that you don't need to have tissue. You can get tissue, but you can also use circulating tumor DNA, and that's pretty accessible. Here's the efficacy comparing tissue, excuse me, tissue and circulating tumor DNA for olaparib, and basically you can see there's no difference. So circulating tumor DNA is a good way to go. When you get your genetics, and I generally favor getting genetics, there's small subsets with a high tumor mutational burden and a mismatch repair deficiency, particularly MLH1, MSH2, MSH6. And it turns out that pembrolizumab is going to be FDA approved here. Now, one of the things that's a little bit problematic is looking at circulating tumor DNA. You don't necessarily have this high TMD greater than 10. That's a tissue-based marker. But if you're using circulating tumor DNA to get your high tumor mutational burden, you probably ought to be 20 or above. You know, we don't have good lessons. We don't have good data there. We're going to celebrate precision medicine, but it only works in 20% of the cases. This, you know, people look and look and look and look. But the vast majority of men will not benefit from traditional precision medicine by genomics. So that's our knowledge deficiency. Face it and move on. You just have to move on. I like the theranostics. I spend a lot of my time thinking about theranostics these days. My title at Mayo Clinic is Director of Radiopharmaceutical Trials. Very simple concept. Something on the cancer cell can serve as a target. You devise a molecule that has a ligand, a linker, and a radionuclide. If you have a particular radionuclide like gallium-68 or F18, you can diagnose. If you have another radionuclide, such as lutetium or actinium, you can treat. And the one that, of course, got the big publicity is the lutetium-177, PSMA-617, or Pluvicto. Supply chains are getting better, but they've been a nightmare. They've really been a nightmare. With regard to the survival, I think many people were disappointed in the survival curves. We were all hoping for better. Here's the RPFS curve. But it turns out that a lot of these patients went on to receive other therapies. And it could be that, you know, I think Pluvicto is a good therapy. It's just we want to do more. And I'm certainly in the want to do more category. Are there therapeutic combinations that deserve to be used as standard of care? The only one I think is really clear is adding olaparib to abiraterone for first-line metastatic CRPC, BRCA-mutated patients. That's now FDA approved. Additional tidbits and caveats. ctDNA as a biomarker, I think, is important. Here's a case in my clinic where we looked at the BRAF K601E mutation treated with platinum. We were using intermittent therapy. We would shrink down the circulating tumor DNA findings, and then it would expand back up and we would retreat, and it would work. So this isn't a case of an extreme platinum sensitivity without a known DNA repair defect. A little bit of an oddball, but nevertheless, I've seen it more than once, and I think it's likely true. With regard to, this is pembrolizumab, you're looking at a patient with a lot of circulating tumor DNA, and those abnormalities go away. That's what you want to see. ND is non-detected. Oligo progression, important. This is a case where what we have is a, let me see, can I make it advance? making an advance. The patient starts out with a multiplicity of lesions on the PSMA. The PSA gets to be undetectable. The PSA starts to rise, and you have one spot. That's called oligoprogression. And here you radiate that one spot, and this patient continued the same therapy for 2.5 years. So that's pretty good. This is a case from Howard Shear. He gave me the slide, so I gave him credit there. Alternative and better dosing regimens. Docetaxel does a little better with the 50 milligrams Q2 weeks as opposed to 75 Q3. 250 milligrams of abiraterone on empty stomach is probably just as good as, with food. 250 milligrams of abiraterone with food, probably pretty similar to 1,000 milligrams on an empty stomach. Not absolutely proven, but certainly good data to support that. High dose testosterone, you got to be careful with it. I'll simply say some people have disease acceleration. We typically use it post-ABI or ENSA. We published on this. This is from the Transformer trial and JCO, Sam Denmead. And basically, on the left-hand side, what you can see is the PSA response rate is pretty much the same as enzalutamide, but more of these patients have PSA progression. And I only used it in patients that I think it's safe to have progression and still not hurt the patient. But one of the really interesting things is after you give a testosterone in a high dose, you can resensitize to the hormonal axis. Here you're looking at a crossover for enzalutamide post-BAT, and you have a 78% response rate. So going from abiraterone to BAT to enzalutamide is a reasonable option for some patients. And I think that's something that the field has not picked up on very well. So brief summary, then we go to Q&A. Multiple agents have been shown to prolong survival. Newer hormones are going earlier. That changes your downstream options. Chemotherapy continues to play a role. I didn't really talk about cabazitaxel, but it continues to play a role, and you cannot dismiss it. Biomarker selection is here to stay, but precision medicine by genomics is only about a 20% hit. And I think the newer radiopharmaceuticals are really going to shape the landscape. I could go on a lot about the newer radiopharmaceuticals. I think a lot about that, but I figured we might cover it in Q&A, but I could put up some slides. We already have, by the way, Pluvicto has been announced positive in the pre-chemo space, metastatic CRPC, PSMA PET positive. So with that, I will stop screen sharing and we'll head on out to the Q&A, and hopefully I'll give a little bit of insight, at least the best I can.
Thank you, Oliver. That was a great summary, and thank you for keeping it short so we can have time to chat. If folks would use the raise hand feature, it should be at the bottom there for you somewhere, and we'll call on people in as they raise their hands. Jonathan, I know you wanted to ask some questions. You submitted some free questions, and there you are up first. So Jonathan Starr, why don't you start us off?
Yes. Yes. Hi, Dr. Sartor. Thank you very much for giving this talk and also responding in advance to some of my questions. As you know, I have a bunch of questions, but I'll focus on my top one first. I'm sort of interested in the things that are in development that might become available soon, that might have some special advantages. And one that I've been following for a while that I've mentioned to you is sabizabulin, also called Veru 111.
Yeah.
And it's in a phase 3 clinical trial, or was, and it was close to completion. But according to what I heard from someone at Veru, sort of late in the game, the FDA informed Veru that this was not going to be enough to get FDA approval, that they would have to do yet another phase 3 clinical trial comparing them to chemotherapy. And Veru is sort of short on cash, and this would take a long time. And all of a sudden, something that seemed promising looks like it's not going to be available.
Yeah, Jonathan, let me just stop you there, because it's not very promising. Okay. And the thing is that it is not a particularly active agent. It's an oral taxane in so many ways. They cast it as a VANCA. The way they sort of ran the trial that I think they wanted to run was not going to pass FDA muster. So they've dropped it. It is not being pursued. I don't think, if you go to the Veru website, and I did to check it out, they made note that they have dropped prostate from the development. So I just don't think it's going to go forward. And to be honest with you, I didn't think it was very promising in the first place.
Well, it seemed to have maybe not better efficacy than taxanes, but a lot less toxicity. And that seemed to be a positive thing.
If you want to do a non-inferiority trial, you got a big task ahead. I'll simply say that they chose not to do it, so it's not going to be developed. I think we can probably move on to other topics, because that topic is not going to go forward.
Okay, disappointing.
Sorry.
Okay.
Yeah.
Up next is Russ Hollier. You can come back for another round, Jonathan. I know you have more questions, but just to spread it out, Russ, what was your question?
My first question is, Oliver, what is your opinion of the step-up trial?
Of which trial?
Of the step-up trial, the bipolar androgen therapy trial?
Oh, I don't even know step-up, but I know the bipolar androgen very, very well. Remind me what step-up is.
Step-up is using bipolar androgen therapy. They're testing two different arms. One is doing bipolar androgen therapy for 3 months, and then enzalutamide for 3 months,
Right.
and then repeating. And one is doing bipolar androgen therapy until progression, and then doing enzalutamide until progression, and interleaving them like that. And then they have a control arm. I don't know.
I like the bat. Unfortunately, I don't think that'll change practice. The way you've described the trial, it's not going to be a true phase 3. But what I'll say is that both are probably reasonable. The data that we have now is where I presented, where you give the bat until you begin to have a failure, then you switch over to the enza. I think that's a good way to proceed, and I'd do it. Whether or not a Q3 month is better or not, it sounds like a Hopkins trial. Is that a Hopkins trial?
Yes, it is. Well,
Yeah.
actually, it's a government. They're funding it, but or they're sponsoring it, but the government is overseeing it.
Yeah, so it'll be an NIH funded trial. Yeah,
Okay.
I think that is interesting. I really do. And I've used it. Probably in about 90 patients is my personal experience. And in particular, the post-enza are re-exposure. And by the way, you can sometimes just go back and forth if you're lucky. So I like the concept. I'm not sure, the step-up trial is just comparing two different ways of doing it, but I don't have any data on the second way. I only know the first way. But I think it's a good concept. Good concept.
Okay. Are you familiar with the XBAT trial by any chance?
No.
If not, okay, it's using darolutamide instead of enzalutamide. I had one other question, and one other pressing question. What do you think of, or what do you think of abiraterone with BAT?
It works. I think the rationale is a little bit better on the darolutamide, enzalutamide, apalutamide because of the blocking. If you're going to be using abiraterone and BAT, you're kind of dependent to what's called the D4 metabolite to block the AR, and that's a little less proven. So I would probably stick with it. I mean, even though it'll work, and I've published on it. I've published on abiraterone post-BAT and with success. But nevertheless, I think that a darolutamide or enzalutamide, and by the way, they're basically the same to me except for the side effect profile. And So all the
Okay.
drugs, apalutamide, enzalutamide, darolutamide, all bind to the same receptor, all bind in a very similar way. The side effect profile is a little different, but the bottom line is conceptually, they're all the same to me.
Okay, thank you. I find darolutamide really quickly. I find darolutamide very easy to take, and Standy was extremely difficult for me.
I would concur. If I had a choice, I would use darolutamide. I don't always have a choice because we don't have a metastatic CRPC indication for Daro.
And it depends on what the insurance companies authorize. Okay, thank you very much. Appreciate it.
Yep.
Next up is Rick Stanton.
Hi,
Rick
thanks.
is a co-founder of the Prostate Cancer Lab, just to introduce him, and he's a bioinformatician, was at Amgen and Human Longevity. So he's very technically knowledgeable. Go ahead, Rick.
Good. Hey, Rick.
Thanks for that. I've got CDK12 mutations. Is olaparib promising for that, or was that a coattail thing, or?
It was a coattail. If you go to the gene by gene analysis, which I actually showed very briefly in the slide, you can go back to the slide deck. The CDK12 is not much. Now, Rick, we have published, and I have more experience on using a carboplatin-based regimen in CDK12, and I've actually done pretty damn well. I mean, I could look up the reference, but if you look up Sartor, carboplatin, CDK12, you'll see a case report where it just really worked very, very well. There could be a little bit more activity if you look at the talazoparib. The talazoparib data in TelePro-2 turned out to be a little bit better with CDK12, but you don't have access to talazoparib, and I still think that the olaparib is pretty borderline at best.
Okay.
Yeah, I mean, look at the data. Go to the appendix. Go to the appendix of the New England Journal paper and look carefully at the gene by gene analysis, and you'll see the data.
Okay.
Yeah.
Thank you.
Yeah, sorry to be a little disappointing, perhaps.
I've got a few questions. I'll try and roll them off. I love your target slide, and we've heard promising things about B7H3.
Yeah.
What do you think about that as a target in the clinical trial that's going on?
Yeah, it's I think it's reasonable. And what I'll say is it's more toxic than what you would prefer. So I will talk to one of my Johns Hopkins colleagues who's given it, and I'll simply say that the toxicity is not so easy. I think it's a reasonable target. I think, there are two B7H3s out there. There's the macrogenics, and there's also the Daiichi Sanyo. I think the Daiichi might be a better way to approach it. But at the same time, I don't know. I don't have personal experience with it, but I think it is a reasonable target. It needs to be explored further.
Okay. We've heard about the Greek test, which is from RGCC, and it's based off of basically a blood draw and ctDNA, and they grow your tumor cells from the blood draw and then submit a battery of tests. It's out of pocket, so I think it's like $2,300. I wondered if you had any comments on that test. Is it worth it when your back's against the wall, or nah? Or
it's I'm not familiar with that particular test, but I'm very familiar with the concept of, like we would in bacteria, we do a culture and sensitivity, right? We culture the cell and then the bacteria, and then we treat it with X different things and come up with a treatment plan. It turns out that you can get biomarkers of resistance pretty well. but finding sensitivity has been a little bit tough. I haven't seen anything that I find totally convincing yet. And so I'd have to learn more about it, but there's smart people working on it. It might be worth a try. I'm not familiar with the Greek test per se.
Okay. I think my last question, because I don't want to, so thank you for your time, but here, I'm on BAT.
Yeah.
And I'm about to find out whether I have significant progression. I think it's mixed. I had a met in my spine disappear, and yet I've had progression in other parts of my body, evidently. So with cypionate, it's a pretty long half-life relative to the duration of the cycle, 4 weeks.
It is. Yeah, I agree.
And so I thought, well, I can get cypionate from my doctor rather than propionate, which is, I don't know, I'd have to figure out how to self-administer. And Russ has been great with, hints and advice, but I went with.
Sorry, if I can interject really quickly, Rick, you can get propionate from Empower Pharmacy if you wanted to. That's
Okay.
And I think your doctor would be able to, we can discuss offline though.
Okay, but I went with cypionate, and I thought, hey, who cares that much if about the half-life? Why don't I put darolutamide in at the half cycle, and then I would kind of get some type of bipolar activity. But my doctors were like, whoa. If we wanted to do that, we'd do that. So stick with. What do you think?
Rick, I have a different opinion than the Hopkins folks. And I'm going to go back briefly to the first case report that I used with high dose testosterone. And I am not at all convinced that BAT is necessary. I don't think you need to go up and then down. I think you need to go up. Now, let me give you the example, and let me give you a way to turn it on, turn it off a little bit better, I think. If you use transdermal, the half-life is very short. If you're using cypionate, you have it lingering around for a long period of time. So the very first time that I was using this, I was scared. And the reason I was scared is I was using it in a very, very advanced patient. PSA was 400 and rising rapidly in a guy who had been through umpteen lines of therapy. And we were just running out of options. So I put on the patch, I titrated it to 1,000, that's nanograms per deciliter, and he responded. There was no BAT, there was no up, there was no up and down, there was just up. Now, that gets you a little bit closer to testosterone control. Now, what you want to do is reset the androgen receptor, and you reset it with a high, not the low. So if I had a little more time on my hands, I might explore something just looking at high T, not BAT. And I think I would come out ahead personally, or at least I would come out equal. But nevertheless, I'm basing that on a very minimal number of patients. And I guess the bottom line is I'm not totally convinced that BAT is necessary, but the high T is necessary.
Okay, beautiful. Thank you so much. I'll yield the floor.
Thank you.
Next up is Robert Germankin. Robert is a dentist, so he comes to us with a little bit of medical knowledge. If we have any jawbone issues or teeth issues that have come up in discussion, he's our expert. Robert.
Thanks. Just two quick questions, or hopefully quick. So one is, I know that PARP inhibitors can be used with BRCA when it's found in genomic, from the tumor. What kind of percent of cells do you need for that to be effective?
Yeah, great question. In the germline, you have pretty fair amount of the BRCA absence in cells, okay? What you need, and a lot of people forget this, we assay for a monoallelic deletion and then use the PARP. But the truth is, in order to get the synthetic lethality, you have to be missing the PARP protein. If you have one PARP allele that is normal, then you're not going to respond to the PARP inhibitors. But it turns out, particularly for BRCA2, that you end up with biallelic deletion, although at times it's a little confusing because it's not always a double mutation. Sometimes it's a deletion and a mutation. Sometimes it's a double deletion. Sometimes it is an alteration, perhaps even in the methylated portion of the promoter, so you don't get expression. So I'll simply say that our science behind BRCA choice is not perfect. With the germline and the somatic, you both are going to do pretty well if you have BRCA2. But on the other hand, it's not perfect, and we need deeper genomics, but we're not quite there yet.
Okay. And the other question is if you can comment on where we are with CAR T.
Yeah, disappointing. You know, every CAR T seems to stop. So there were two that have been looked at. Number one, looking with the PSMA as a target, another looking at PSCA as a target. One was done by Bellicum and the other was done by, oh hell, I forget. But it's disappointing. And if you want to look globally at disappointment, look at the solid tumors and CAR Ts. I think there's just a lot of heterogeneity, and we need something more than the CAR in order to hit it optimally. And, you know, we know with the biospecifics you can get it. One of the reasons I like isotopes is what I call the umbra and penumbra. When you bind to an isotope and you have something like lutetium, you not only radiate the cell that it binds to, you radiate the microenvironment. That microenvironment can include blood vessels and stromal supportive cells. And you're basically treating the tumor as a whole, even when there's heterogeneity in the expression of whatever your target might be on the tumor cell. I'm worried with CAR T, you need to have a little more homogeneity. And where you see the beautiful CAR T responses is in the hematologic malignancies that have much more simplicity. They don't have the same degree of aneuploidy. You know, this is an aneuploid tumor, and we don't talk about that enough. There is huge heterogeneity in the chromosomal. We're looking at ctDNA. We're not assessing the ploidy status. There are whole genome duplications, whole chromosomal arm duplications. I'm telling you, it's complicated as hell.
Okay, thank you.
Good. I hope that helps, Robert.
Jonathan, another question.
Yes, thanks for coming back to me. So thanks for the answer about sabizabulin. Now, next is about other drugs that have been in development that seem to hold some promise. And let me select out the sort of other AR-oriented drugs, like the N-terminal domain inhibitors and the AR degraders.
Yeah. Yeah. So
it's like
yeah.
ARV.
Yeah. So
okay.
ARV-110 is probably going to go into a phase 3. There is a second Arvinas compound. I'm sorry, I forget the number. They just had a announcement on it, which may be even better because the ARV-110 doesn't hit the 702. You know,
766.
That's it. AR-766, Arvina 766. Thank you. Who said that, Rick? Yeah. Anyway, thank you.
Yep.
So
Sorry, I went back on mute. Yep, it was Rick.
Yeah. No. Thank you. You know, there's clear activity within the H75, H78, which are the more common mutations, and it looks like the newer compound may hit the 702 as well. they're trying to cast it as overall ligand binding domains, but you'll take in things like 716 and 877. But the data is not very strong there. But the AR degraders are potentially interesting, particularly if you have a mutation. Whether or not this new 766 is going to hold up, I don't know. I need to look at the data more carefully, but I'm very familiar and an author on the 110. The N-terminals have been disappointing to date. You know, the first N-terminal turned out to be a real failure. The second N-terminal did have a response, and I haven't gotten an update on that. It could be interesting, but part of the problem is after you inhibit the AR with abiraterone and enzalutamide, now you're beginning to have tumors that are driven by non-AR components. The AR components are getting smaller. And when you're starting to run into things, you know, more P10 loss, more RB loss, and the AR-driven tumors are present in a minority, but they just you're not gonna kill them all, and you also have to deal with the problem of heterogeneity. So after you're going through Abi and Enza or apalutamide, darolutamide, whichever one you want to use, you're ending up with only a minority of the patients being AR driven, in my opinion.
Okay. And my final question, if I can have it, is about Sipuleucel T.
Yeah.
I've read about this Proceed study where they looked back at huge 2,000 patients, scaled by initial PSA, and it appeared that, or baseline PSA, and it appeared that that there was a pretty strong correlation in disease-specific survival between baseline PSA and disease, PSA and disease-specific survival. I mean, on the order of years, several years of difference. So like in the lowest quartile PSA survival was
Jonathan, I'm an author. I'm an author on all those papers. I know the data.
Okay. All right. Well, you sort of dismissed it earlier in your talk today.
I did.
Yeah. Why?
Well, because it was developed in an era when there was no Abienza, there was only Taxotere. And we really have entered into a different realm today. And I am a little skeptical about the one positive randomized trial published in 2010 and nothing that has followed that in a randomized way. What you don't know is they had another randomized trial that failed and they never published it. And there's no RPFS, there's no PSA, and the biomarkers are inconsistent. I am not very strong on Sipuleucel T based on 13-year-old phase 3 data. Show me something new, and then I'll be more enthusiastic. But you better use it in the current landscape. Don't go back and crank up the ADT and docetaxel as being your only treatment alternatives.
Well, isn't that Proceed study something new?
No, the Proceed study is first of all non-randomized. Second of all, it's a real-world data. And third of all, if you look and see when most of the data were published, in order to get that long-term follow-up, you have to start a long time ago. So that real-world data is pretty good, but it's not controlled. Look, I'm an author. I published it. I think if you're going to use Sipuleucel T, you use it early. That's where you get your biggest benefit. But on the other hand, I just think we have better drugs today, and I really haven't used Sipuleucel T in my practice in a while.
Okay. All right. Thank you.
All right. Next up is Russ again.
Hey, Dr. Sartor. You mentioned constant testosterone. I just want to make a quick comment.
Yeah.
I did RP, and then I did 4.5 months of ADT, and then I did 2 years of constant testosterone. My PSA went from 0.01 or less than 0.01 to 0.17 over 2 years. And then I've done BAT for 2 years. My PSA dropped to less than 0.01, and now it's slowly risen. My PSA naders are about 0.1. Just a comment. I'm only N of one, but constant testosterone worked very well for me, I think.
I think it's very interesting. And I, if I had a little more time on my hands, I would pursue it more, because I think there's some interesting elements there that we just haven't fully understood yet. Look, I have many friends at Johns Hopkins. They're my friends, they're my collaborators, but it doesn't mean I agree with everything they say. And I think that the BAT has gotten a little bit fixed. I think there are different ways of doing it, perhaps, and that it's going to take a little while to get it unraveled. But I applaud the investigation into testosterone. I think it's very interesting.
Gives you great quality of life too.
Yeah,
thank
sure
you.
Does.
Thank you, sir.
Absolutely.
Next up is Brian McCloskey. He's co-founder of the Prostate Cancer Lab. He's in Atlanta because he's been dealing with the death of his mother, so we send him our condolences.
Thanks, Brad. Thanks, Dr. Sartor. I did want to make one quick comment on Provenge. I use it. I saw actually no benefit from it, either through PSA or through radiographic view. So N of one, but take it for what it is. My question really is about understanding precision medicine and digging into that a little bit deeper. One of the challenges that I've seen as a patient going through this process is that there really is not quite an emphasis on advanced diagnostics. So a lot of it is focused on select gene panels. And so I've really pushed on that lever in my treatments. I've had 3 different lesions over 6-7 years that have been sequenced. I've had DNA sequencing. I've had RNA-seq. I've also had proteomics. And one of the things I found in working with Tempest in comparing my RNA-seq for all 20,000 genes is my expression relative to 1,000 advanced prostate cancer patients. And I use that information to identify targets that I think would work versus those that wouldn't. So for example, if we look at PSMA, my expression relative to 1,000 patients is only in the 38th percentile. So I'm really not too excited to go after, for example, Pluvicto, when I'm looking at my AR expression to be in the 98th percentile. So I use that, plus I've got AR copy number gain. I have a high AR expression through proteomics, and I've gone after BAT. So I just started BAT. But I wanted to dig a little bit in terms of get your thoughts in terms of how does RNA, how do proteomics fit into the landscape of precision medicine? I don't think that we're really leveraging a lot of the advanced diagnostics that are sitting in life sciences companies.
Yeah, Brian, I agree with you. You said a couple of things that are interesting. You talk about RNA-seq. Let me kind of explain what that is, so we get everybody on the same page. First of all, when we're looking at typical genomics, we're only looking at the DNA. And we talk about circulating tumor DNA, or are we talking about the typical genomics? There are 2 major types. There's the germline, of which you're born with, and there's a tumor, which is in your tumor. And we're looking at things like BRCA2 mutation or deletion or something like that. Gene expression is a completely different approach. And I think it has the potential to be very powerful. The problem in general has been getting pure populations of cells, number one. Number two, it turns out that DNA sequencing is really powerful and RNA is really unstable. So you can do RNA analysis. And by the way, there's some really interesting things that have come out of Decipher, which is a way for prognostication that's an RNA-based approach. But RNA stability is a real issue. And when you use the formalin-fixed tissue, you often end up with very degraded RNA, and it's hard to get really good signals. Proteomics could potentially help to overcome that. I think we need to leverage proteomics. I think we need to leverage exosomal cargoes. I think we need to leverage circulating tumor cells. I think we need to leverage RNA expression, all of them in more detail. one of the things, and this is a little bit unrelated, but it gets to what I think is your very important point, is how do we classify these tumors anyway? And, you know, you talked about individual expression patterns. It turns out there's a beautiful manuscript that was in Science last year from Cornell, and it broke down CRPC into 4 components. Number 1 was the typical adeno, and that was about 50%. But in addition, there was a stem cell that nobody is really talking about. Everybody talks about adeno and neuroendocrine, but the stem cell is probably more important than neuroendocrine. It's characterized by certain transcription factors, AP1, but we don't know a lot about what's on the cell surface. We don't know a lot about that. We don't necessarily know how to treat it very well. And then there's a Wnt driven, and Wnt pathway is one of the oncogenes that's quite important in a number of tumors. And it's probably going to be important in prostate for probably somewhere around 8 to 10%. But nevertheless, classification with novel methodologies, RNA, better DNA, including whole exome or whole genome, running RNA-seq, running proteomes, all of those are going to be, I think, part of our future. We're just not quite there commercially yet.
Okay, thank you.
Yeah, but you raise a good point.
That's a good segue to Alan Morris, who's a pathologist, as we were mentioning. It's there in his lab. Alan, what are your questions?
My question, so this biomarker stuff, this genomic stuff concerning prostate cancer is new stuff. It turns out that some of the prostate cancer patients in this lab have overexpression of HER2/neu. And the reason I bring that up is this is not new. This has been, we can stand on the shoulders of breast cancer. HER2/neu has been investigated and is well vetted concerning breast cancer. And there has been a recent sea change in breast cancer where, let me give you guys a background. Pathologists semi-quantitatively graded HER2/neu overexpression on a 0 to 3 scale. And forever, HER2/neu positive was only considered 3+. Well, there's a current sea change in breast cancer where even 1+ and 2+ are now, instead of being considered negative, are considered low expressors. And that's vis-a-vis this new class of drugs, the antibody conjugates with HER2/neu. And they have, this isn't something novel like BH73 and whether it's super duper toxic or not. This thing has been vetted in breast cancer and has shown incredibly positive results, so that it is revolutionary in breast cancer. And the reason I say this is because one of the oncologic principles that you are relaying to us is that earlier is better, that all these things that have been vetted in the metastatic castrate resistant space have now been, a lot of them migrated all the way back to hormone sensitive state. And the idea is that you want to start these things earlier. Well, I guess my opinion, and I want your advice on it, is anybody that's a HER2/neu overexpressor should run and get this treatment that's already been vetted in breast cancer. They shouldn't wait around for trying to figure out what the right sequence is, which is never going to be found out in this short period of time of 2 or 3 years right now, which is the window that we have.
Gosh, you know, the only problem is something called payer approval, and they won't do it. And so what you're going to do is, if you can afford $20,000 in infusion, you can get it. But the insurance companies won't do it until they have an appropriate trial run in prostate. I agree with you. The drug is called Enhertu. I made a reference to B7H3 and the Daiichi Sankyo a little bit earlier. They're using the same warhead in Enhertu and the B7H3 from Daiichi Sankyo. But the problem is the drug's not available unless you can afford to pay. And I think it'll be $20,000 in infusion. So That's the problem. You have to do the trials. And then you have to do the trials and get the FDA approval.
Let me just comment that the standard of care in the United States is 1 year of treatment, but in Europe, they get equivalent results with 6 months. So I think there's a lot of people with means here. It would be 6 times 20,000, which is actually in the same ballpark as Cipilocil at 100,000, unless the price tag has changed.
Right. Yeah. The only problem is one is paid for by insurance and the other is not. That's the distinction.
Let me just check in on time. We've come to the hour here. Oliver, do you have a few minutes, or should we wrap?
I do. Brad, I'm fine. Let's keep going. I don't want people's questions unanswered.
Okay, there are a few more questions teed up here. Alan, were you finished, or did you have another one?
I'm sorry, I get excited. I have to apologize to everybody. I'm sorry, Dr. Sartor.
Okay. All right, then Jonathan, another bite at the apple.
Yeah, thank you. First of all, what is the name of this drug for HER2?
Enhertu, ENHERTU, I think it is. Enhertu. Yeah, it's a topoisomerase 1 put on the HER2 antibody. It's an antibody drug conjugate. It's the best antibody drug conjugate I've ever seen. It is the best antibody drug conjugate I've ever seen, period. It really has been a game changer in the HER2 positive breast cancer field.
Can I just jump in here for just a second? I want to dovetail a little bit of the information I have on my proteomics. My proteomics and my RNA-seq actually showed that I had HER2. Using any limited gene panel diagnostics, it never identified HER2 for me. So I know, for example, with RNA-seq, my expression's in the 75th percentile for advanced prostate cancer patients, and my proteomics confirmed that a little bit. So trastuzumab was actually put on my list of potential drugs. And I think this is an example of how you can use more advanced diagnostics to identify patients who might actually benefit from this drug. How many advanced prostate cancer patients even know that they have HER2?
Yeah, Brian, it's interesting. You know, we don't know a lot about the expression, and I think it's going to be modulated in part by the prior treatments. And so I think it could be an evolutionary acquisition. I actually think that when you look at the HER2, it's a good target. But here's the problem, Brian. You can't go from an unvalidated biomarker to a treatment. You really have to put the two together. You have to walk in your biomarker, walk in your treatment, and do the trial in order to show that it's going to work. Because otherwise, the expression patterns, you know, it may not even be on the cell surface. And the way Enhertu binds, it has to be on the cell surface in order to be active.
Yep. Okay, that's good insight. Thank you.
Yep.
Okay. Well, thanks for that. I don't know. Just thinking over what you've said today. You know, I was hoping to get some sense of what we could hope for going forward. BAT seems to be, or at least high testosterone and enzalutamide resensitization seems to be a possibility to be excited about. But what else? It seems like that's it.
No, you didn't. Nobody asked me until now what I'm excited about. And
what are you excited about?
I'm really excited about the targeted alpha therapies. You know, so first of all, I mean, let me give a little bit more data on the lutetium. So lutetium is going to be FDA approved, in my opinion, in the pre-chemo metastatic CRPC PSMA PET positive space. That's going to be a huge sea change from the VISION trial. I think it'll open it up to probably triple the number of patients. There's a press release on December 5th from Novartis saying that trial is positive, but it's yet to be presented in a public forum. That public forum may come up in the fall. And somebody you know might be presenting it. The data that is more conjectural is in the upfront metastatic hormone sensitive space with lutetium. And that trial is accruing very, very well with ADT, choice of hormonal therapy, plus or minus PSMA lutetium. All right, that's PSMA lutetium. I could also bring up the SPLASH trial, also pre-chemo, preliminary data at ESMO last year. Looks good enough. I think it's going to be a positive phase 3. All right. The other phase 3, which is worth mentioning, and I don't have a lot of enthusiasm for it, but the atezolizumab plus cabozantinib trial, the CONTACT, was it CONTACT 2 or CONTACT 3, whatever it is. Some people think that could be a pretty reasonable winner, but the data for the actiniums is really the best data that I've seen. And some of the data is absolutely outstanding. Have you seen any of that data?
I have not. I thought it was very toxic, though.
The most toxic thing I can think of is advanced prostate cancer.
Well,
That's pretty damn toxic stuff. I may put up a slide right here. Let's just see if I can pull one up real quick. This is I think this is worth talking about because I think it's something that is potentially important. So hang on just a second. I'm going to display my screen one more time, and we'll go here. And can you see that?
Yes.
Yes.
Okay. So this is from a lecture I gave I think I gave this in South Africa. No, this is post South Africa. I forget where I gave it. Anyway, it's a lecture I gave on Swimcom. So first of all, the alpha particles are 2 protons, 2 neutrons. They're really big compared to the beta. They're about 7,000 times bigger. And something we call the linear energy transfer is monstrously bigger. And that's the damage that it causes. The range in tissues is extremely small. It's only about 40 to 100 microns. And that's important to know. There are a whole variety of alphas that are being looked at: astatine 211, lead 212, actinium. But actinium is probably in the lead. Here's kind of the basic landscape right here. Convergent, Telix, Bayer have antibodies. PSMA INT is now with fusion. Point's developing. Novartis is developing. Bayer is developing advanced cell, ITM, and more. And this is without prior Avi-Enza using actinium-225, PSMA 617, Mike Suzetsky out of Pretoria, South Africa. And that's his waterfall plot in the 617. Now, what's the problem here? The problem is the salivary toxicity. That's the issue. This is a fascinating article from Mike, and very recent. This is hormone-sensitive prostate cancer without the hormones. There's no hormones being used here. And this is the actinium-617. Now, the toxicity, I think, still needs to be further explored. And, one of the things that we know, and this is from Mike, you end up without a lot of salivary glands, but I think we're going to work on that. I think we're going to get better on the salivaries. And one of the things about the alphas is they work post-beta failure. And, here's an alpha post-beta failure. People are looking at it. This is also from Mike right here, looking at zoledronic acid with actinium. So the bottom line is, I think that we're going to have solutions here. I think it does have toxicity. but I think there are ways to get around it. I think the J591 is interesting. That's out of Cornell. But we're going to get more exploration. This is out of Fusion, plus relationships with immunotherapy, possibly, and more. There are a lot of commercial alpha programs that are ongoing, and you got to be aware. So that's just, I'm pretty excited about this stuff, and I'm trying to get more, get my hands on more and moving forward.
Okay. All right, so we can hope for that. Okay, well, I'll yield the floor again.
All right. Thank you, Jonathan. Russ, you're up next.
Thank you. Just have one question here. What is your opinion of during BAT of using cypionate or propionate? Propionate with a short half-life, 1 day, cypionate with a much longer half-life.
Yeah, good question, Ross. I don't really know. I've used cypionate, but
oh, you have used propionate.
No, cypionate.
Okay.
CYP. I've only used propionate a little bit. I've had a little bit of luck with it. I had a patient over at the VA that got it, but I just don't have a lot of experience. I think it'd be great to look at comparative trials. One of the problems, Russ, and this is something that really bedevils the field. Clinical trials are really expensive. So something like the PSMA edition is probably a $250 to $300 million trial. I put that together with Scott Tagawa. You want to do big trials, you better spend big money. And the problem is, on a non-commercial product, you can't get anybody to put up that kind of money. You just can't do it. And you can write little trials, you can play around, but if you want to do practice-changing trials, you're going to have some real money behind it. And that almost means pharma. And pharma is going to use IP-protected compounds. And that's how you're going to get the $100 million trials. That's just the way it is. I don't like to say it, but it's true.
Yeah, for profit. Kind of understood. Yeah. Understand, but thank you very much for your opinion. Thank you.
Yeah, and Russ, I like what you're doing. It's just hard. It's hard to get it done in the proper way.
Yeah. Thank you.
Yep.
Okay, Russ. Next up is Rick Stanton.
Yeah, I want to pass because I already had a question. I'd rather hear from Rick and Eric, and I'll follow up at this time.
Rick Davis, nice to see you. It's been a while.
Hello, Dr. Sartor. Last time I saw you was over the coffee table at the GU ASCO. Durability. We've talked a lot about some good stuff like the radionuclides and testosterone. But I'm really interested to hear your opinion on durability, especially with testosterone and radionuclides, not early in the game like with Russ, but where people are using BAT late in the game because they don't know what else to turn to. How durable is it? And the same thing with the radionuclides. How durable are they and how often can they be used?
Yeah, so good questions. And the radionuclides, we know a pretty fair amount. And one of the things that's a little bit interesting is the degree to which the and I'm gonna throw up I might throw up a couple of slides here again real quick to help answer your question. And so let me come up to the share screen real quick, and I think we can do that. But the bottom line is that we know, so on the Vision trial, the median time to radiographic progression-free survival was about 8.7 months in very, 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 very advanced patients. That is not good, but a lot, if you want to look at the PSA decline as a predictor of survival, it's surprisingly good. For those people who get a good PSA decline post the PSMA lutetium, the survival is really, really, really good. And I'll simply say that we're needing to get more data on this. For the bat, it's a bit disappointing. The bat as a whole is on median is probably going to be, what is it, around 4 to 5 months. But of course, some patients do extraordinarily well. We have patients that have done extraordinarily well, but a lot of patients don't respond at all, or may even have disease acceleration.
How about repeating the bat or repeating the radionuclide? Have you had experience with that?
Yes, we definitely repeat that if we go from bat to say ENZA and then back to bat and then potentially back to ENZA, we've done that, Rick. In some patients, it seems to help. I've got a guy down in Alabama right now who's kind of migrating back and forth between bat and ENZA, and he's doing pretty well. And by the way, I put darolutamide in there and apalutamide probably in the same category. And I do prefer darolutamide, but it's hard to get unless you have the indication.
And repeating, how about repeating radionuclides? Because that's an issue we see more and more. The guys want to repeat it 8, 9 months out when they.
Yeah, the problem is that the data that we have is predominantly out of Australia and a little bit out of Germany, and it's non-reimbursed. So I think if you had a good response and then relapse, going back to the radionuclide would be a reasonable option. But the problem is insurance is not going to pay. And now we're talking, if you go to Germany, if you go to South Africa, you can get about 10,000 a dose. I don't know where it is in Germany right now, but I would guess it's probably somewhere between 10 and 20,000 a dose.
Yeah, Turkey too. And how are you treating men? Because we have at least one man on this call right now in this category. How are you treating men who are hybrids, who only partially respond to the radionuclides because they have both cells that express PSMA and cells that don't express PSMA?
Yeah, that's really a conundrum. Phase 1 trials we use are, cabazitaxel carbo is a really nice drug combination. Some people do quite well with cabazitaxel carbo, and even cabazitaxel cabazitaxel is a real drug. It's in the Australian trial, it was head-to-head compared to Pluvicto, and there was no difference in survival, even in their FGG selected patients. So, don't forget about cabazitaxel. It's chemotherapy and nobody likes chemo, but it's a legitimate drug.
Thank you.
Hope that's helpful.
Next up is Eric Hall. Eric, good to see you.
Yeah, hello. Thank you. Thank you, Dr. Sartor. So I want to ask a little bit different question, I guess. I'm in a little bit different place than a lot of these patients. I'm still kind of new to the prostate cancer journey. I was diagnosed last July with metastatic. I've been on abiraterone and Orgovyx this whole time, and I had surgery, radical prostatectomy, and pelvic lymph node dissection in February, but I had positive margins. So I'm kind of looking at what are my next steps there. So yeah, I mean, it's high risk because I was Gleason 10. So I guess my question is, you've talked a lot about, promising future things. Would that change how you might treat someone like me, given that that's coming in the future? Like I know you mentioned some of those things are kind of like pre-chemo, showed a lot of promise, for example, right?
Yeah, Eric, are you on hormones now?
Yes, I am. I'm still on the Abby and the Orgovyx.
Okay, I would anticipate your PSA is probably undetectable.
It's undetectable right now.
Yeah. Did you get a PSMA PET scan prior to your surgery?
I had not prior to surgery. I had one for my original diagnosis.
Prior surgery.
Okay, and you said oligometastatic.
Yeah, I had one lymph node show up I had one lymph node show up on the PSMA PET, as well as I had the extracapular extension. My tumor. My tumor
Was that a pelvic lymph node or an extra pelvic lymph node?
pelvic lymph node.
Yeah. Okay. So, what I might be tempted to do, and this is, we're entering into an unknown area here. So first of all, let's acknowledge that the beneficial effects of hormonal therapy in your setting there's one study. It was published in 1999 by Dr. Messing, and he used lifelong hormonal therapy for node-positive disease and said people did better. Nobody does that today. Nobody. So what I might be interested in doing is stopping the hormonal therapy after X amount of time, and we can talk about what X is because nobody really knows, and waiting for the PSA to rise. If it does, then doing your PSMA PET scan and trying to find out where the disease is now. We don't know if your surgery removed that lymph node, and even if it did, the standard of care for pelvic lymph node positive disease is not surgery. They've done it in Mayo Clinic, and what they found out was if you went and plucked the lymph nodes, you didn't do very well. I heard your Gleason 10. I don't like that. On the other hand, treating the pelvic lymph nodes with radiation in combination with hormonal therapy is a pretty good way. But on the other hand, we have PSMA PET. I would use it. I wouldn't keep you on hormones forever. And one could use a 2-year hormonal therapy, but that's sort of out of the blue. I'm making it up. I mean, we don't really know. The Stampede trial used radiation in 2 years and had very good results, but they used combined radiation and hormonal therapy for 2 years. So you're kind of out there. We don't have data for people like you.
Yes. Yeah, I'm considering adjuvant radiation right now.
It's not necessarily unreasonable, but I might keep you on the hormones for X amount of time, then let the PSA rise up and try, if it will rise up. It may not rise up, and then repeat the PSMA PET so you can give a boost to exactly where the radiation is needed. But we're getting pretty conjectural now. I mean, nobody can promise you the right path forward.
Yeah. I have 2 unique genetic mutations. I have a CHEK2 mutation and I have an ALK fusion.
Oh, wow.
Yeah, which is not.
That's really rare.
Exactly.
Right,
Emma was on the call earlier. She could attest to the rareness of that.
Yeah. What's the ALK fused with? What's the partner?
DTNB.
DTNB. That's a transcription factor. I don't know much about that. Gosh, I would have to go looking at it. The CHEK2, I would say, is not actionable right now. That ALK is really weird, and I'd have to go look at it.
Yeah.
I wouldn't be able to give any opinion off the top of my head.
Okay. Could I email you with a couple other questions about that after?
Sure. Yeah, I'll put my email in there. It's sartor.oliver@mayo.edu.
Awesome. Thank you very much for the time.
Yeah, you're welcome.
Rick Stanton, do you want to ask your question now?
Sure. I used to be a bioinformatics scientist back in the day, and we had hopes for personalized vaccines, and we would sequence whole exome. It seems like it's really hard to do or get anyone to do it. It seems outside of the mainstream, and I don't know whether an interesting question came up. Do you know anyone who had actually helped? And my answer was no. Even though we would match, try to, whether it was a driver mutation or not. So any comments on personalized vaccines?
Yeah, it's interesting. The only data that I can recall off the top of my head was in melanoma. And I actually think that it worked. And I'd have to go back and read about it a little bit more, but it actually may be feasible to do. I'm looking at the I'm doing a quick search. Moderna and Merck on December 13th of 2022 did a reduction in disease recurrence with a personalized cancer vaccine. And this is not one that I have a lot of familiarity with, but I think it's encouraging. It's going to take a lot of effort. So first of all, as you know, prostate is a pretty cold tumor. But there probably are some epitopes that could be exploited. It'll take genuine science in order to get that done. It's going to be incredibly expensive, but I think it ought to be done. But I have not worked with Moderna, and I think they're likely going to go with lower hanging fruit and buy things like melanoma first, because there you have such a wide variety of epitopes. These are hot tumors. I think they're going to go hot tumor before they'll go cold tumor.
Okay, thanks. The other question was, since I'm getting spread in my bones, what do you think of Xofigo? I think you mentioned it, but I shied away from it because I just felt like it was swirling down the toilet bowl of death and not, just would wipe out my bone marrow, and it scared me. But, now I'm about to see whether BAT worked, and I don't maybe have too many other options.
Well, how many meds do you have?
I don't know. I'd say 10.
10, that's a lot. Okay. It's kind of interesting. You may or may not know that I'm senior author on the radium-223 paper.
I did not.
Well, and you might also be interested. I was also senior author on the cabazitaxel paper, the phase 3. So, I've been around these agents for a long time. I know them intimately, from running the trial to taking it into commercialization. That said, the radium data to me has been a little bit like the sickle cell T. It was performed in an era when there were no patients who had abiraterone or enzalutamide. We had the P3 trial that will be coming out with enzaradium, but the abiraterone in combination with radium was a debacle. It was the ERA-223 trial. So I am not that keen on radium as a whole. If you were PSMA PET positive, then I would think about the Pluvicto, and I just think we have a little better angle with the Pluvicto on PSMA PET positives.
I already did
yeah.
Pluvicto.
Now, you've not had any chemo?
I have. I've had the taxane, docetaxel,
Right.
and I've also had Pluvicto.
Oh, you've had Pluvicto.
Yeah, I had 4 rounds of Pluvicto, at which point my PSA was rising.
Okay.
And, when I failed Pluvicto, that's when I started BAT.
Got it.
I had a washout period of 6 weeks where my PSA went from like 8 to 24 in that washout period. And then I started BAT and it went to 112. And so now I'm about to see, do I take my third BAT?
If you had two bats that went from 24 to 112, I would probably say no.
Mhm.
But now you're in a conundrum. I would want to know your genomics. What genomics do you have?
CDK12.
Yeah, the CDK12. I would treat you with cabazitaxel carbo.
Okay.
Yeah. Look, I'm going to look up real quick. I'll give you the reference. Yeah, but I mean, you're facing a tough situation. All right. We published this, long-term disease control using taxane platinum-based chemo and CDK12 mutated advanced prostate cancer. We published it in the Oncologist. I'll put the reference. I'll put the citation in the
Chat.
in the chat.
I was hoping to go back to darolutamide.
Oh, I'm sorry. I'm sorry. No, you should go back to darolutamide, or you should go back first. I'm sorry. I apologize. You'd already had it, but now you're in the post-BAT period. I apologize, Rick. You should go to darolutamide or enzalutamide as the next step, but this would be your step after that.
Okay.
I apologize for not getting that. See if I can get it. Yeah. Okay. No, because right now you're in that post-BAT period. You're probably progressing, and I would go to an AR antagonist, and I would probably not choose Abby. I think darolutamide would be fine, and enzalutamide would be fine.
Right.
Yeah, I apologize, Rick, but this is your plan B.
Got it. Thanks for your time.
You're welcome.
Dr. Sartor, now we're at an hour and a half. How much more time do you have before we've got a couple more questions yet?
Yeah, I'm fine. I'm fine.
Okay.
You know, I mean, look, these are real questions.
Yes, they are.
For real people. No, they're, you know, I mean, obviously this is tough stuff. And, you know, to the extent that I can be helpful, I enjoy being helpful if I can be.
All right. I'll keep the recording going. Brian, you're up next.
Okay, I'll make this quick. Okay, so just as you talked about, you know, what are the treatments that you're excited about? I'm going to go back to my inclination. What are the diagnostics that you're excited about? If you could wave a wand and you could have every patient go through certain diagnostics that they're not getting today, what would they be?
Yeah, great question. You know, I'm really starting to have greater interest in the whole genome sequencing, which you can do remarkably cheap now. And admittedly, that's another look at the DNA, but there's a lot going on in DNA that we don't fully appreciate it from the targeted exomes that we're getting today. I think we're just going to have a lot more information. I really would enjoy the transcriptomics in more detail, but I don't quite know how to do it. Because if we look at the beginning, like a radical prostatectomy specimen, that's not when you want to get it. These tumors are plastic. They, you know, people have used different terms for it. Lineage plasticity is one of the common terms that is used. And I'll simply say that it's very, very real. When you induce a selective pressure called treatment on a tumor cell, it evolves and then comes out in a new way. We need to understand more about that. I love the transcriptomics, but I don't quite know how to do it. But I'd like to get whole genome. And by the way, even low-pass whole genome in the context of circulating tumor DNA can be very valuable. One of the things I mentioned earlier that we're missing is the degree of what I'm going to call aneuploidy or whole chromosome generations and duplications. There's a beautiful manuscript out that shows that the ploidy status, the overall aneuploidy and ploidy and the chromosomal arms are more important than the individual mutations. And we have no handle for that. I'm trying to press for that. I'm working a little bit with Tempus, and maybe they're listening, maybe they're not. They act like they're listening, but they're not there yet.
Interesting. If you are interested, I can send you just a quick table that Tempus and I worked on. Rick was part of this as well, where they looked at my RNA expression from my prostatectomy in 2016, met lesion in 2020, and a met lesion in 2022 for all 20,000 genes, and looked at my expression for each of those genes relative to 1,000 advanced prostate cancer patients. So you can start to see, is it morphing over time? Are new things popping up? So you get a little bit of a sense of that. The complexity is very huge. If you're not familiar with that and you're interested, I'd be happy to send you a little snippet.
Yeah, no, it is huge complexity, and this is where we have to do a lot of exploratory work. I don't even think we begin to know about the potential interactions. People talk about the dark matter, the non-coding RNA. It's really important. There are things like SHLAP1 that are out there. These non-coding RNAs are a whole new world, and we don't even know what to think about them. And it's important. So we've got a lot of work to do in order to really optimally personalize therapy. We're at the beginning right now, not the end.
Yep. Okay. Awesome. Thank you.
Yeah. Thank you.
Jonathan, you're next up.
Okay, thank you for yet another turn at bat here. Thank you, Dr. Sartor. My next question for you is, I've read about these DEP cabazitaxel and DEP docetaxel. These are products of I think it's a Dutch company called Star Pharma that has been going through clinical trials in Europe, not here. But the essence of them is that they are sort of different formulations of docetaxel and cabazitaxel. I think it's like the nominally non-active ingredients are different. And because of that, they have far less toxicity than just regular docetaxel and cabazitaxel. At least that's what I read. My guess is you have some familiarity with those.
Just a little bit. And I have really, in my own mind, tried to emphasize novel agents. I mean, going back and doing another version of docetaxel or cabazitaxel is not very entertaining to me. It may diminish the toxicity a little bit, but I'm really more after new targets personally. And by the way, I haven't mentioned other interesting targets like HK2 or STEAP1. But yeah, I would rather not recycle the old. I'd rather go look for the new, because I know the best you're going to do is to come out with something that is probably maybe a little bit better than docetaxel, maybe a little better tolerated, but it's not going to be a game changer.
Well, what about those two you said, STEAP2 and HK or EZH2 or?
Yeah, EZH2 has been disappointing so far. There've been a couple of, it's a great target, but it just doesn't turn out that it's as druggable as we thought it was. Either that or there's more to the story. STEAP1 looks a little bit interesting. I'm not able to fully comment on that simply because it's unpublished data and it's proprietary. But I'm keeping a lookout on STEAP1. HK2, I'm keeping a lookout on HK2 as well.
Okay.
Yeah.
All right. And I sort of missed what you said about the ARV 766 and 110. What your final word was on that.
Yeah, no, I think the ARV 110 is going to be good for the 875, 878 mutations in AR. But it's not going to hit a 702. The 766 looks more interesting, but I haven't had a chance to deep dive in the data yet. I know ARV10 backwards and forwards. It's an active drug in selected mutations, particularly the 875, 878. Beyond that, it gets a little more conjectural.
Okay. Okay. Thanks again.
I'll
yield again.
Robert Germankin.
Okay, thank you. So you earlier talked about prostate cancer being cold immunologically.
Yeah.
So I have the markers and I'm going to be starting pembrolizumab soon. Is there anything that I can do to kind of make things better situation?
Robert, let me understand. You said you had the markers. Which markers do you have?
I have high mutational burden, MSI high. I have 2 of the mismatch repair
Oh, wow.
mutations.
Okay, yeah, no, you might be lucky, Robert. The most spectacular results that I've ever seen, maybe in my entire life, has come from Pembro and the high MSI mismatch repair deficient. What's your mismatch repair deficient gene?
I think it's MSA.
They're MSH2, MSH6, PMS2, and MLH1.
Yeah. Give me a second, I can find it.
Okay.
I should know this off the top of my head, but I guess my question is, what, if anything, can I do to, amp things up even more so, if possible?
Yeah, I don't know, but certainly you ought to give the Pembro or another PD-1 or PD-L1 inhibitor a try. And how high is your TMB and what was the assay?
It was 23, and that was
not super high.
As far as, so here it is, the immunohistochemistry. So I'm MLH1 positive and PMS2 positive.
Okay, positive there is not positive. That means you don't have the mutation.
Oh, okay. Then it's MSH2 and MSH6.
Okay, and they were missing. They said negative.
Yeah.
All right, so that's good. And so MSH2, MSH6 are the 2 that are more likely to respond.
Okay.
Give the Pembro a shot. I don't know how to ramp it up, but give it a shot. It might serve you well. I've had spectacular responses in your situation.
Yeah. The other quick question is, going through 6 rounds of docetaxel, is that likely to improve the situation in terms of the microenvironment?
I don't know. I don't know.
Okay. All right. Thank you.
Yeah. No. Well, let us know how you do on the Pembro. That's important.
Okay. Thank you.
Yeah.
Eric Hall.
Yeah, thanks again. I'm going to go back to my my adjuvant radiation question. So if I decided to do adjuvant radiation, would that maybe potentially limit or impact any choices for me down the road?
Probably not. You know, it's an interesting question that if you were known to be what I wish I had in your case is the post-op PSMA PET scan to see what it looked like. We know you're margin positive and you had a single lymph node, right?
Yes.
On the pathology.
Yep.
Did the single lymph node come from where the PSMA PET was positive on the pelvic lymph node at the beginning of your diagnosis? Or was it someplace else?
No, yeah. I mean, I'm not sure I understand your question. Sorry.
All right. Did the surgery get the PSMA PET positive node?
The surgeon said there's no way to guarantee that.
Okay. Was it in the same vicinity? Was it on
Same
the right
vicinity,
side?
yes.
Same vicinity.
They
Okay.
took 25 nodes, 13 from one side, 12 from the other, and it was in that chain that
Just one positive.
there was one positive, that was in that chain that they took.
Yeah. You know, it's an interesting question. We don't have data for men in your situation. What was your post-op PSA?
It was undetectable 6 weeks post-op.
But you went on the hormones anyway.
I was on the hormones for about 8 months prior to surgery.
Ah, okay. So your post-op PSA has no meaning.
Yeah.
Okay.
Because
Yeah.
my PSA at diagnosis was 146, and so they put me on the hormones to start with.
Oh, okay. Yeah, that's really high. That's really
with the Gleason 10. So
yeah. No, you had metastatic disease. We just don't quite know where it is. I didn't realize you were that high in the beginning.
Yeah.
You know, it's a hard call, but I'm not completely sure that I would go with the pelvic radiation. Because you just don't quite know. It's a reasonable shot on goal because it's where it was, and you can do it, but you're kind of operating without a lot of information.
Mhm.
It's
Even with
hard
the
to-
positive margins?
the positive margins are likely problematic. If you stayed on the hormones for 2 years total, you'd be treated like you would be in the Proteus trial, which we don't have a readout on yet. And how long have you been on hormones now?
Almost 11 months.
You know, Eric, your margin positive is not good. Your lymph node positive is not good.
Mhm.
You're being treated in a manner that's a little bit unconventional, and so the water is really muddy. We don't quite know where you are. You could radiate the pelvis, in which case you would certainly radiate the margin positive,
Right.
but it's not a straight shot on goal, in my opinion, particularly with your PSA being as high as it was initially.
Yeah. Do you know if there's any kind of trials or tests that look at like biomarkers or anything to determine the efficacy of or toxicity of radiation therapy prior to doing it? Because I've gotten a lot of data, a lot of different tests.
Yeah. There's nothing really good, no.
Okay.
And what about your genomics? Do you know anything about your genome at the diagnosis?
So, well, I told you the CHEK2 and the ALK fusion.
I'm sorry. Yeah, that's right.
But I also did the liquid biopsy, the Garden 360, and I had the MET A354A, the IDH1, and the EGFR show up as somatic alterations.
Was that drawn at the beginning, prior to any therapy?
Yes, prior to all therapy.
So your ctDNA did not match up with your other genomics, because you mentioned the ALK and the CHEK.
Correct. Those came from doing whole exome testing.
Yeah, I think that's more reliable. I'm not sure I would put much credence on the ctDNA. I think it's a tough call, Eric, as to whether or not you radiate the pelvis or not. I personally doubt if all your disease is in the pelvis. I don't know where your disease is. Part of me would be interested in finding out where the disease is, but you're being treated with hormonal therapy. There's good hormones. You have an undetectable PSA. There could be a rationale for going up to 2 years and then stopping and seeing what happens. Or you could radiate the pelvis too. It's really you're living in a data-free zone, unfortunately.
Yeah, and you say that maybe not do the pelvic radiation because you're saying you believe there's probably other spots outside of the pelvis.
I think there are other spots outside of the pelvis. I think the margin positive is real. In fact, there's no doubt about it. That's real. And I know the lymph node is positive, and that's real.
Yeah.
But I wonder about how much more there is to the story and how long, since you started on this hormone journey, I wonder about how long you should continue it. And you could radiate. It's just the issue here. I'm surprised you only had one PSMA PET positive lymph node at the time you were diagnosed with a PSA that high.
Everybody has been surprised by that.
Yeah.
Yeah, no bone mets, nothing.
Did you have conventional imaging?
Yeah.
And nothing?
And no, it showed the same lymph node.
Okay. Yeah, you're a tough case, Eric. Radiate the pelvis, plus or minus. Probably knowing what I know now, I'd probably say 2 years on the hormones. And then, you can't target the CHEK2. The ALK, I'd have to do more work on that in my mind.
There's one thing maybe I didn't share as well as I could have, is I had what I call extracapular extension. So my tumor was extending outside of the prostate and was touching the rectum. So it was sizable. It was like 5 by 4 centimeters, I think.
Yeah, that's another thing about local control that could be an issue. By the way, the recent data presented from Piece 1 did in fact suggest that radiation in the pelvis could help with local control later on, and we'll go from there. But yeah, you've got a tough case, and you could kind of go either way. You're in a data-free zone.
Quick question, why wouldn't you radiate? What's the downside? I mean, I did.
Yeah. The downside is that you don't really know what you've accomplished with the current therapy. The upside is maybe you can eradicate. He told me now that he had T4 disease with rectum. So that's kind of pushing me more toward the radiation. Extracapsular extension, margin positivity, initial T4 disease, plus lymph nodes. Clean up the pelvis and then go from there. The downside is that when you deploy the radiation, what you want to do is you want to boost where you can boost. If you're going to use typical pelvic radiation, you're going to go about 45, 46 gray to the pelvis, and you don't know where to boost. And 45, 46 might be enough, but I'd rather boost it if I knew where it was. The problem is with his case is you're going to deal with a generic radiation and not know exactly where to radiate. If you do a little more detail, you might know how to pull out the radiation a little better. That's my conundrum. But the radiation, Eric, after you told me about the T4 extracapsular extension, positive margin, and lymph nodes, maybe the radiation of the pelvis would serve you better. I think it can be done with a minimal amount of side effects, but it's still not a clean call.
Yeah. Okay. The positive margin is at the bladder neck.
Yeah.
And
yeah.
So
Get a good radiation oncologist. Where are you being treated? What's your location?
I'm in North Carolina, but I've been seeing Mayo actually.
Okay. Yeah, well, the Mayo guys are good. The radiation up here is actually exceptionally good. It really is.
I've been talking with Dr. Ryan Phillips from radiation.
I enjoy Ryan very much. He's very thoughtful. He's very good. I know him well. I like him a lot.
All right. Thank you for your time.
Yeah. If you want to, I can discuss your case with Ryan.
Yeah, I might email you more about the ALK also and with Dr. Phillips also.
Yeah, he's a good man.
Okay, thank you.
Okay, the longer we go, the more questions keep coming up. Alan?
Yeah, thanks. Dr. Sartor, you were considering, and I can't remember the patient's name, you were considering that he would be a good candidate for Keytruda by virtue of him having mismatch repair deficient genomics. He then asked, what more could I do to help? And what came to mind to me is that in melanoma, with double checkpoint inhibitors, they have astonishingly got Kaplan-Meier curves to settle down at about 50 to 60%. Admittedly, double checkpoint inhibitors are very toxic. If he were at the end of the road, would you not possibly recommend him trying double checkpoint inhibitors to enhance his possible response?
You know, the problem is payment. That stuff is $25,000, $30,000 a dose for the IPI. You know, that's it, and you know, there's not a bad rationale for doing it. But I guess the problem is, you know, how many doses do you need? I mean, that's $100,000 out of pocket if you get 4 doses. And it would be out of pocket. No insurance company is going to cover IPI.
Did you see the July 2022 New England Journal of Medicine article concerning rectal cancer and just one checkpoint inhibitor on mismatch repair deficient patients?
I did.
Yeah.
Yeah, everybody had a complete remission. Actually, I have a major quibble with that paper. Let me tell you what it is.
Okay.
Everybody quotes rectal cancer.
Yes.
And they do not specify the mismatch repair. And it has generated so much discussion because they don't emphasize every single patient was mismatch repair deficient in that trial.
Well, the person that you were talking to is mismatch repair deficient. So they would fit into that cohort.
No. And I said, you know, I would say go with Pembro. But by the way, the Pembro that they're still, you know, to me, the PD-1 inhibitors are all the same. So I would not draw a distinction. You know, everybody talks about the drug. The mechanism is all the same. I think you could have gotten the same thing with either Pembro or Nivo.
Well, how can you say that when double checkpoint inhibitors are efficacy is superior in melanoma? There are different checkpoints that are being hit.
Right. No, I'm saying that the reason that the IPI is not really accessible is the cost of the drug, the lack of trials, and the extreme cost, and the fact that there's no insurance that's going to cover it. So it's really hard to make a recommendation unless the patient's willing to put out a huge amount of money.
Right. I mean, we are in the context of some people that are at the end of the road. So admittedly, obviously, the studies haven't been done in prostate cancer. So it would be the leap of faith, going from rectal as well as melanoma.
No. But the rectal was only a PD-1 inhibitor. It wasn't a double IO.
But I agree with that. But all the more reason that checkpoint inhibitors show unbelievable promise, and in melanoma in particular, that promise is improved with double checkpoints. I'm just addressing his one question that is there something else I could do? And there is, though it would be costly. There's no prostate cancer trials concerning it.
Are you?
Never mind.
I guess to be honest with you, that it's hard to recommend a combination for which we just don't have much data. So I don't typically recommend that we go in a space where we have no data at all in prostate. Now, the combination has been looked at in prostate, but not in mismatch repair.
Yeah.
Your point is well taken that maybe adding IPI could be better, but I don't think in my practice it'd be a typical recommendation.
Yes, because you don't want to stray from what's proven. I understand that.
It's, we have really good responses with Pembro monotherapy. And if you look at that rectal cancer series and the mismatch repair, one of the things that is evident is the melanoma did not have mismatch repair, whereas the rectal did.
Yes.
So the rectal with only PD-1 inhibition led to complete remission in every single patient. So you may not need the IPI.
Yes.
What was the second checkpoint, CTLA-4?
Yeah, CTLA-4, ipilimumab, which is the checkpoint inhibitor.
But in melanoma, they're using multiple combos in as far as in trials go, to try to mainly to try to reduce the toxicity, because the combination is incredibly toxic.
Yeah, they're playing with the dose. They're going with the IPI 1 milligram per kg instead of initially they were using 3, and that helps. And they're cutting down the IPI to 4 cycles and not going further. But with mismatch repair, hopefully the PD-1 will get you into a really good spot.
Not to jump in, but I'm the one you've been talking about.
Yeah.
Any place for a PARP inhibitor in conjunction?
No, they there was initial enthusiasm for that idea. The studies came out of the NIH. They initially looked promising, but they haven't panned.
All right, thank you.
And Robert, we don't mean to talk about you as if you weren't there.
No, that's perfectly fine.
You have a very interesting case.
Thanks.
Jonathan?
Thanks again. This is probably a quick question. Now that you're up at Mayo Clinic and they have C11 choline imaging, I think they still do.
Yes.
Are you going to utilize that? Are you going to use it in combination with PSMA? Or if PSMA comes out negative, try C11?
Probably not. There are a couple of issues with it. If you look at the trials where they've been done together, they're actually head-to-head trials looking at choline and PSMA, and choline's just not as good. Now, there are a few people who believe that maybe the choline is a metabolic marker, may be different, but that I don't envision using a lot of choline.
Okay, even if someone is PSMA negative, you wouldn't.
I would. It depends on how high they were. We've got other trials, things like GRPR, that may be a little more interesting there. I mean, choline could be in the PSMA negative setting. The fellow that had the very high PSA might be a case where choline could be considered. But as a routine, I would not use choline. It would only be potentially in very restricted patients.
Okay.
Yeah, there's a phase 3 trial comparing the two. I don't know if you saw that. And let's see if I'll pull it up. Phase 3 choline versus PSMA. And the let's see. I would here it's a Journal of Nuclear Medicine, fairly recently published. Detection rates are higher, and head to head, there's no doubt that head to head PSMA is better. And again, we come into the reimbursement thing. The insurance will pay for one PET; they're not going to pay for two. So if you want the second PET, you'll have to pay for it.
Yeah. Okay.
I try to be pretty sensitive to patient pocketbooks, but maybe patients ought to be aware that you can do more imaging. We just don't always know what we're going to get.
Yeah. Well, I paid out of pocket for C11 acetate when it was available, and it was much better than anything else available. So it's
it was the best in the world before the PSMA PET came along. Yeah.
Okay. Thanks again.
All right, I think it's been 2 hours.
Wait. Could we hear from Noelle? Because she's had a very interesting chat comment.
So Philip is a patient of Dr. Kwan's, and we just met with him. Phil just had his 4th Pluvicto treatment. His PSA has been steadily declining throughout treatment, but he told us after his 6th dose, we wait 6 weeks, we go back. He's not giving him a PSMA scan. He's giving him a C11 choline scan.
Okay.
Do you know why that would be? And I did ask. He just says they like to use it because maybe it'll show something that the PSMA didn't. But we've had trouble in the past getting the choline approved where the PSMA has been approved a lot easier.
Yeah, I would be more likely to use the PSMA PET as opposed to the choline PET.
Well, and I guess the issue I have with it is since we've been monitoring throughout treatment with the PSMA, if we look when treatment's completed and we use the C11 choline, now we're comparing apples to oranges. Like I would prefer to use the same scan throughout. So we can, effectively compare it.
Well, I would likely agree with you. I just put in the chat, by the way, the direct comparison. When they looked at the comparison of the PSMA PET and the choline, the PSMA PET or the choline PET contributed in only 6 patients. And that was out of a total of, let's see, I think it was 200. And well, let me double check the number. 190 patients. So in 6 patients out of 190, the choline was better than the PSMA.
Yeah.
But it's a low probability event.
So yeah, we'll maybe have to discuss that.
Yeah.
And I don't want to hold you up any further, but you had a chart you displayed earlier, and you said typically with patients, Phil has a pretty low disease burden. I mean, he's got just 3 spots.
Yeah.
And he's been doing well. When we started, his PSA was 0.81. It is now 0.11, and he just had his 4th treatment. So we'll find out. But it's been steadily declining throughout. I think when I saw your chart, you said those patients typically do pretty well.
Yeah, they do extremely well. That's a much lower PSA than typical in that setting. But what I'll say is, if you're down to 3 spots, why don't you SPRT them?
Well, we asked. That's funny because I had actually asked that. We were a little worried about Pluvicto and thought maybe save that for later because he gave us the option initially of either. And, we were supposed to come back, and then we were put on a waiting list, and we were supposed to come back and have a consultation. But what ended up happening is we're on that waiting list forever. And then when we came back for the consultation, it was more, nope, here we go with treatment. So, and I even, Dr. Stish, if you're familiar with him.
Yeah,
we like him.
I know him very well.
Yeah, so he did some SBRT on Phil, 2 years ago? Yeah. 2 spots, put Phil in remission for almost a year.
Mhm.
And now he was on Xtandi after that. So, or that's what got him into remission, was the SBRT plus Xtandi. And then just last fall, the Xtandi started to fail, but he's still on the Xtandi and doing Pluvicto, and we're 4 treatments in.
Yeah. Well, I mean, I would be interested in taking another look at the PSMA PET. If you're positive, consider SBRT to those remaining lesions. And, that's a reasonable, I mean, that's probably how I would handle it.
So are you available? Like, are we be able to arrange to see you when we come for our next visit? Do you see patients? I mean, is that something you can do?
Yeah, I see patients, and they have to be a little bit careful about the diplomacy between departments.
No, I
you know what I mean? But yeah, no, no, of course I'm seeing patients. I've been seeing patients for 33 years.
Okay. Yeah, it might be worth, we haven't been able to get a lot of answers. We're very grateful for the care there, but we haven't been able to get a lot of answers about his specific mutations and things. So maybe it would pay to sit down with you.
Yeah. Well, I think you can go through the Mayo portal and make that request if you like.
Yeah, absolutely. Thanks for your time. This has been awesome. Really appreciate you staying 2 hours.
Well, my heart goes out to the prostate cancer community. I know you guys work really hard in an effort to press boundaries and come up with the right solutions. And practicing medicine is very much of an art form in these circumstances. And, good people may or may not necessarily agree with the same approach. I can certainly say that. Dr. Morris's mention of the ipilimumab will be an example. If you had unlimited funds and were willing to tolerate a lot of toxicity, then maybe you go with a combination of 2 checkpoints instead of 1. Could be. I probably wouldn't do that myself, but it is, there's a rationale for that. There's, one can construct a reasonable argument for making a case.
Okay, I think that was starting to wrap. If you'll allow, it's been 2 hours. I think this has been a very generous contribution for you, Dr. Sartor, and also your candor. I know that many of the folks we have on shy away from giving what sounds an awful lot like medical advice. I know we talk about this boundary between medical information and medical advice, and we know that you're sensitive to that as well. But it's been we very much appreciate your candor and your personalization. I'm sure everybody's walked away with information that's very useful to their specific cases.
Good. Well, thank you, Brad, and glad to be able to be here. And about the medical advice, just as sort of an example, in a real medical consultation, the fellow that had the T4 disease with rectal invasion, and his initial PSA of 176 or whatever it was, that colored my interpretation of the case. Was initially presented as margin positive, lymph node positive, but I didn't hear about the PSA being well over 100. I didn't hear about the rectal involvement. So, that's one of the things that's a little bit of a danger about trying to get medical advice, because I don't really have all the facts. In a real consultation, I sit down before the patient's in the room. I review all those facts before I ever walk in the room.
Yes, and we're well aware of that. So we really appreciate your going. I don't know if it's, I was going to say going off half cocked, but at least, based on the evidence that you have, which may not be full. So anyway, just your appreciation and willing to go out on those limbs and make those comments. Thank you.
Well, you're welcome. All right, guys.